Hi, Jennifer.
Hi,
Welcome to HIMSS. It's always a pleasure to see you.
thank you.
So, how has HIMSS been so far? What do you feel about the vibe?
It's exciting. There's so many different things going on in so many different booths. It's hard to know where to even begin looking at everything.
Absolutely. So, congratulations on a great presentation, right? A lot of interest. So, thank you for doing that. So, let's talk about again just because people are seeing this for the first time. Obviously, you've done some tremendous work with revenue integrity, which has impacted CMI, CCM, CC capture rates. So, do you want to just talk a little bit about that? How is that impacted culture and change and driven revenue improvement?
Yes, one of the ways that it's driven revenue improvement is our CDI team isn't staffed to cover 100% of cases. So we're able to use Medi as a backup, like an auditing system to help us catch any cases that only had no CCs, no MCCs, so we can flag those cases and have a dedicated reviewer go back in and make sure that we haven't missed anything. Because staffing is an issue. We're only able to review about 55% of our discharges a month, whereas when we have Medi, we're able to have our claims data find 100% of the cases that maybe would be going out the door with no CC or no MCC. We also build a report for low-weighted DRGs, things that don't have a CC or an MCC but could potentially be moved to a better, more specific diagnosis that would be in a better DRG to capture more of that acuity. So,
Awesome.
yeah.
Now, I also remember that you use the insights and the analytics to influence physicians,
Yes,
right?
yes.
And pretty amazing education thing. Can you tell us a little bit about that and how that has impacted physician behavior and coding and again resulting in improved?
Yes, we're able to take our physician insight data, say for example neurosurgery, where we know our capture rate of CCs and MCCs or our case mix index is not reflecting that how heavy of a patient load we feel like those cases are. Physicians are saying, oh, we have the most complex cases. Well, it's not really being shown through our CMI. So we're able to show them our cohort data. You can see the diagnosis that are most frequently comorbid conditions for each DRG. You can show them their cohorts, how much of a variance there is between our capture and their capture. Like a big one in our craniotomies might have been like a brain compression. And they say, oh, well, there's some degree of brain compression with any time you do a craniotomy. Well, if you're able to show them, well, the cohorts are also saying that's a condition they're monitoring, evaluating, treating, and that's important for us to document. And that has helped us improve our case mix index in there. And then also being an academic medical center, research is a big part of our mission. So you want to have the other comorbid conditions as well, so you can tell, to pull maybe patients into a study or to tell, what potentially diagnoses that were there for that type of drug or study we're doing. So helping show them the data and the diagnoses that are in a DRG and variances from our cohorts is very important because what they may consider a patient that's not that sick is a critically ill patient that a community hospital would be transferring immediately. So the data is easy to use. We love it because you can pull your data by a physician at a department level. It's very easy to do, so you're not getting every different department for each DRG. You can pull it at a department level. Then you can differentiate between your vascular surgeons and your CTS surgeons, and that's super helpful.
That's awesome. So it sounds like life-saving impact, life and death impact,
It is.
which is always formidable. A last question. I know you're using the data to impact length of stay, right? So tell us a little bit about that, because that's where you're going to. It sounds very exciting.
Yes, this is our newest project that we're using our Medi data for. We're trying to improve our financial performance through improving our length of stay and understanding our length of stay. So we have a wonderful account rep who can help us customize reports. Again, we can do it by a department level, but we're able to see our length of stay compared to the GLOS. And then we can tell our differences between elective surgeries, urgent surgeries, emergent surgeries, so they can see where the variances are there. We can also pin in data and show where the discharge disposition of the patients was. So it can help our departments understand, well, does this department maybe need more help with case management to help move these patients through the system? Or is it a documentation issue? Yep. Is that you're not getting an accurate length of stay because your documentation is missing those CCs, MCCs? And also, is it a quality issue? Are we not able to get the patient into surgery if it's the emergent and urgent categories? So it's helping our team understand what is going on with our length of stay. What are the different competing factors? And we've started taking that data out to each of our individual sections, and they're finding it to be very enlightening. It's just not a number, it's broken down.
That's awesome. So sounds like things that we're going to be talking about in the next webinar and at the next HIMSS. So on that happy note, Jennifer, thank you so much. It's such a pleasure to work with, and you amaze us always with the insights and the passion that you bring.
Couldn't do it without our fabulous account rep who works with us every 2 weeks to really drive our data and get the right reporting. So we love that.
Kudos to Nusha Davison, who Jennifer's talking about, for a job well done. Thank you so much. Please enjoy the rest of HIMSS.